All right, we're transitioning to Q&A, and Deb, tell us what you see in the chat area or in the poll question area.
So there are 3 questions that I connect to the new federal rules. So should I read those 3 together and then you can kind of go from there?
Sounds good.
If discussion, sorry, can you summarize the Cures Act components for mental health clinicians? And then the 2 related, if a patient has a history of violence, sorry, or their feelings would be, okay, has a history of violence or their feelings would be severely hurt, looking at their notes, would that fall under the definition of harm, allowing the note to be excluded from the record? And can you define the difference between a counseling note and a psychotherapy note? Did you get those 3?
Maybe start with the first one again.
So Steve, do you want to give an overview of the Cures Act as it relates to mental health notes? One of the Steves, whoever feels.
Sure. Well, I would say, so I'll try to tackle it a little bit. So I would say there's a little bit of confusion, and I would actually, between all the various systems and the interpretation about some of this. But the general sense has been that that we're not supposed to exclude groups of patients per se, but you can exclude patients on a case-by-case basis. So you can't say all psychiatric patients should be excluded from opening up notes, but you could exclude certain patients on an individual case-by-case basis. And that's a little how many of the systems are just opening it up in that regard. And I would also say that some systems that, it looks like there was an out where it says psychotherapy notes are excluded, but that, then it gets into the definitions of what's a psychotherapy note and all of that. And that's a little something where I encourage all of you to kind of get to your folks in your legal department and your information management department to find out your system's clarification about those particular rules. Because what I'm hearing across the country is that it varies from system to system quite a bit, and there's a bit of confusion about that in that regard. But many systems, because of expediency, are simply saying, well, if we're opening up all the medical side and we've got some pretty good data here on the mental health side, why not just open everything up? And so that's actually what's happening, is that there's a whole groundswell to just open it up in that regard. So I don't know if my colleagues have anything else to add about that.
Hold on, I think I muted you, Steve. Let's see. Unmuting Steve Dobscha right now, and go.
Thank you. I know I was drinking coffee, probably making noise. Anyway, I just wanted to echo that. I think the specific circumstances that you can block for, my understanding, is completely at this point. And so I like the idea of connecting with your institution to make sure you're at least all using the same types of standards. Getting back to maybe the second question, if a patient gets upset, again, we found probably a good third, maybe even a little more, reported some upset from the notes, but most people want to keep seeing the notes. It was really a very small number, 10%, who reported frequent upset. So I don't think that, I can't imagine the standard would be, if you're just going to get some upset, that you should be blocked.
I think, my understanding is that the harm has to be physical harm. So psychological distress is not part of the harm definition. Is that right, Steve or Steve?
I've seen different interpretations about that. Both.
Okay. Okay.
It generally starts with the physical harm is really what it is, but the worry is that the emotional harm could lead to physical harm or something. So that's another aspect of it. And I would also add that, just as Steve just mentioned about, particularly patients in the VA with PTSD, who then sometimes would read the note and get more upset. We found that, I've certainly seen that anecdotally. We haven't studied this, at least on our end, but I hear this pretty regularly. A lot of our clinicians who are working with, for instance, rape trauma patients, they put in a lot more lurid detail than probably is necessary. So then the patient then reads the note, or it's domestic violence patient or whatever, that when they read the note, it recapitulates the experience, and so it re-traumatizes them in a way. And that's a little what's going on there, I think, in terms of the psychodynamics. And that's something just prepare patients for in terms of when they might choose to read a note. So
a question for Steve Dobscha. Those 46% of clinicians who would be pleased if open notes were discontinued, What is your theory of how much of that desire is driven by the extra time, energy it takes to write the open notes versus more closed notes? And another person had a related question. I'm curious if open notes causes providers to spend more time on writing the note. The documentation process is already very burdensome, contributes to burnout. Can you suggest ways to streamline and reduce rather than increase the time a provider spends on documentation?
Yeah, I actually think the additional documentation burden is pretty minimal. And Steve did a much better job of talking about this. It's a couple of words here and there. It's not really, and I mentioned acronyms, but as I've thought about it, acronyms isn't really an issue either. So I don't think the notes take that much longer to write. And I think that's been our experience. I think it's more you have to be thinking about it, thinking about what you write, and maybe a little bit about how you write, maybe adding a few more details. But it's not there. I think the extra time may come in when a patient wants to talk to you about it, and I think that's probably one of the barriers to why clinicians don't bring it up. So one barrier is they might worry about a bad outcome. Maybe they're nervous about, what the patient sees, but another one is that they're probably worried that the patient's going to start talking about it in session. And I think you'd have to handle that the way you handle any new issue that comes up in a session, right? Sometimes you might want to dive in and you may end up with a better patient alliance because of it. Because you've had that discussion and you've explained what's going on. Other times it may be distracting you from other types of activities. But writing the note doesn't really take much more time.
Yeah, I would add on the writing the note part. Actually, our staff found it was a little less of a work burden than it was expected. An average progress note takes around, in our system, takes 7 to 9 minutes to do, and an intake evaluation takes between 45 and 52 minutes. That's what it was. And I found some of my staff that were struggling with the open notes. One of them was her average progress note was taking her 28 minutes. To do, and so she was writing way too much. I mean, that was, and so her efficiency got much better because she realized she didn't even need to do all the notes, and she was writing things in there all the time because she was afraid she was going to forget stuff from session to session. And so, she just keeps side notes now is what she does, and puts in the basic stuff that she needs to put in there. So
yeah, notes have been increasing in size for ever since we got our electronic medical record here in the VA since 1998. The amount of time clinicians spend in it anyway, the length, it's just tremendous how they've increased. And I don't think open notes is really a big factor.
A question for Dr. Dobscha: any sense of the impact of open notes on adherence to big league psychiatric meds?
Big league psychiatric med. Not quite sure what that means. We don't have any. What's that?
Psychiatric meds in general, let's say.
Right. We don't have any data, and I have to say I'm moving off into different areas. And if anybody who works in the VA wants to reach out, I'd be happy to talk to them about future projects. But as far as I know, no one's looked at that in the VA system. I don't know how you'd study it, because the other thing is that VA open notes just went boom, big bang across the VA. So it's hard to, it's a little bit hard to tell. You could look for associations between adherence to medications and so forth. And we did find in our little study, or relatively small study, that patients reported impacts on their adherence, but we didn't look at the meds in the record.
How do you deal with intake evaluation notes where the assessment may still be ongoing, diagnostic impressions are preliminary, or intakes a trainee conducts where they need to consult with a supervisor before giving feedback to a patient, but a patient may get to prematurely see that intake note?
Is that for me or for Steve?
Either way. Go ahead, Steve, if you want.
No, you go ahead.
All right. So I think that generally when you're uncertain about something, you put those things in. But mostly, I would say probably the biggest increase of staff, if there's any change, people use a lot more quotations. They put in a lot more things that are directly from the patient, I would say, in that regard. And if they put down, their diagnostic impressions, if you're putting out something that's a rule in or rule out kind of a condition, you are putting in your diagnostic impressions. We should not be, turning over your professional obligations to patients. They should not be able to choose what you put in the note in that regard. That is still your domain, right? There is patient autonomy, but there is professional autonomy as well. and you've got certain obligations to put that in there. It's more about explaining that to folks. And as for our trainees, they're obligated to say, you know, at the beginning of the therapeutic relationship in all, I believe it's in all states, that they are supposed to inform someone that they're a trainee and that they are under supervision. And so that should be something that is part of the initial informed consent in a discussion right off the bat. So that's what I would say. Liz?
I'm jumping in to let you know that we're at time. There are more questions here than we have time to answer today. So I want to make sure, invite everyone who's still logged in to our office hours next week, which is on Tuesday, January 19th. I just put the registration link there with information in the chat area. If you join us, it's just an open discussion with Dr. Dobscha, Steve O'Neill, Director of Open Notes, Kate DeRoche will be there answering some of your policy wonk questions, the whole crew, and would love for you to join us. Unless anyone else has anything to say, wave your hand. I want to say thank you for everyone for showing up today and attending this webinar. You will receive an email in about a week with a link to the recording of the session, links to the slides, and any other resources either of the Steves mentioned in today's presentation. And thanks to them both for sharing the research and real world experiences with sharing mental health notes with patients. Thank you, everybody.